Welcome, everyone. Thank you so much for joining us tonight for the first of our webinar series for the ADIA. We are very happy to have Amy Drewery here with us tonight and looking forward to a great presentation. And I will, without further ado, hand it right over to Amy.
Okay, thank you, Tara. So thank you guys for joining tonight. I know it's evening and family time. And so thank you guys for taking an hour to jump on with us tonight. We're going to have some fun, hopefully keep everybody engaged. I know you might be tired or hungry or both. And so I'm going to do my best to keep you guys entertained while we learn a little bit tonight too. We're going to talk about clearly, five mistakes that undermine case acceptance. Today, it just kind of hit me. There's actually a sixth one, so you guys get some bonus content tonight. As I was thinking through some things, I just really had to add another one. So let's carry on here. Unfortunately, the mistakes that we make, are a result of our education, our training, our experience, all of the things that that encompass our upbringing in dentistry. And that's what's frustrating because we've all been trained to do certain things, to communicate with patients in certain ways, to present dentistry in certain ways. And the problem with that is dentistry has changed. I mean, we're in a different realm right now. Dentistry has evolved, and I'm not just talking about the clinical aspect. I'm talking about the way people make decisions, case acceptance. There's a lot to that really isn't like it was even a few years ago. And so I'm going to ask you guys to have some pretty open minds tonight, because I'm going to turn some things upside down, compared to what our traditional roles have been like in dentistry. So let's dive right in. The first mistake we make is we talk way too much. Okay, we do. That's, again, we're trained to do that. We're trained to tell and explain and educate. And as a result, we end up talking too much. Patient isn't talking very much. And we're not listening, because there's not anything to listen to. We're doing all the talking. The problem with that is, again, in an attempt to educate, establish credibility, all those things, we unintentionally create roadblocks to case acceptance. And that's a problem because the patients don't feel heard, they don't feel understood. When we explain and educate, many times we do that in a different on a different level. Okay, we talk techno talk. We talk use dental terminology and things that frankly are confusing to patients. They don't understand it. Some of them do, but a lot of times we're just overwhelming them and confusing them. So we're going to talk about what to do since we're talking too much. But that's the first thing. I want to make sure that we embrace that first. This is probably the most important one. We are so intent again on explaining and educating that we miss the fact that we're not even asking the patient's perspective. We're not trying to find out what motivates them, what's important to them, what they want to accomplish, because we're so busy looking in their mouth, telling them what's wrong, and then giving them a solution, and then trying to convince them why they ought to do it. And that's not effective anymore. So I would like for you guys to think of our case presentation or case, I call it case acceptance process, because, case presentation indicates that we're going to present something. Well, let's switch that and totally change the way we see that. It's case listentation. Patient needs to be a part of that process, because when we talk more than the patient does, we are inadvertently communicating to them that what they think or what they feel is not important. So here's what we want to do. We want to create a a communication where the patient's talking 80% of the time. We're talking 20% of the time. Okay, it's usually flipped, or probably more like 90-10, dental people and the patient maybe gets 10% in. We want to completely flip that. And so, that seems a little overwhelming for people who haven't heard this or aren't used to it. It's like, well, what on earth are they going to say? Because they're counting on us to tell them what they need, to tell them what's going on, etc. But just hang with me and I'll help you understand what that's going to look like. So how do we stop talking? Okay. Well, we need to seek first to understand. Instead of, we want to listen with the intent to understand what people are saying, rather than, if we are listening for a short moment, oftentimes we listen with the intent to respond. We're waiting for people to stop talking so that we can tell them what's on our mind. I'm afraid I do that with my husband a lot. He's from East Texas. He's a slow talker and he loves to tell stories. My brain is, my ADD brain is always a few steps ahead, and I'm like, can you hurry up with the story? Because I'm ready to talk. And that's a fault I have. That's a problem I have, because instead of listening with the intent to understand, I am listening with the intent to respond. And that's not only ineffective, but it's rude, frankly. So we want to listen with the intent to understand. We want to be intrigued by our patients, be interested in them. We feel like it's the Dr. such and such show. We spend so much time trying to build value for the patient. Well, let me tell you something. We cannot build value for other people. We simply can't. All we can do is find out what they value and then match our solutions to what they value. Okay. Because trying to create value for something without understanding or knowing first what's important to them, what motivates them, that's kind of a futile effort, because we haven't asked. So that's where we've got to start, is be interested. Ask, don't tell. I'll tell you, when I was learning this type of communication, I had to put signs all over the office that said ask, don't tell, as a reminder for me to ask questions. And I promise I'm gonna let you guys know what questions are helpful and beneficial in these situations. But that was a reminder for me, because we got, we were just so indoctrinated in terms of how we educate patients and explain things and tell things. And that's what we did. So we've got to be curious. We have to be curious about their perspective. The problem is we are so busy and intent on trying to drag patients into our frame of reference, because we feel like if we can do that, they're going to see things and understand things the way we do. And if they see and understand the things, things the way we do, then they're going to make the right decision. Okay. They're going to accept treatment. They're going to move forward, whatever. But that is the wrong kind of thinking. What we need to do is really get over ourselves, step out of our frame of reference and get over into theirs, and be curious and understand, how are they thinking? What is important to them? What do they value? What are their long-term objectives for their teeth? Instead of just, dentists looking in their mouth, telling them what's wrong, and then we try and sell them on that treatment. So we've got to be curious. The way we do all of this, and seeking first to understand, ask, don't tell, be curious, be interested and intrigued by our patients, so we have to ask questions. And the kind of questions we want to ask are open-ended questions. Now, I don't want to make any assumptions, but we'll talk about how an open-ended question is defined. But again, I love this quote by Stephen Covey. If you've never read 7 Habits of Highly Effective People, it's a long book. It's a pretty intense book. But, one of those habits is seek first to understand, like we mentioned earlier. But again, we listen with the intent to reply. If you haven't read 7 Habits, pick it up and at least read that chapter, that particular habit, seek first to understand. It was pretty, I don't know, life-changing for me, honestly, not just in my communication with patients, but in my communication with my family, with people in general, because we all want to be heard. And because we all want to be heard and understood, we oftentimes dismiss others. And so getting in that habit can make a huge, huge, huge difference. All right, so let's talk about open-ended questions here for a minute. Open-ended questions start with what, how, when, why. They allow a much higher level of engagement. Patients are going to maintain ownership of their situation, whether it has to do with the health of their mouth, their financial situation, their schedule. It allows them to maintain ownership. That's one of the problems that, kind of a sneak peek ahead. That's one of the issues, is that we tend to steal ownership, and we're going to talk more about that. But open-ended questions are unique to the patient. I'm going to share with you guys some examples of open-ended questions. I'm also going to share a QR code here in a little bit that you can scan and get lists and lists and lists of open-ended questions if you'd like. But one of the things you want to be cautious of is making sure that you don't memorize the questions. Say, okay, this is great. I like these 5 questions. I'm going to ask every patient these 5 questions. Because the problem with that is we're putting the patient in a box. We are, not simply having a conversation. We're just, checking boxes. So I want to encourage you, as we begin to talk about open-ended questions and their effectiveness in our communication with patients, that you remember and realize that they are unique to the patient. While I'm going to give you a lot of examples, I want to encourage you to come up with your own. Because when you understand the concept of open-ended questions, and we understand the concept of ask, don't tell, wanting to establish a foundation that's built upon the patient's goals, what motivates them, what's important to them, even their fears, things of that nature, then we understand how we can best help them. Then again, we can take that foundation, that information, and match it to the best solution. Now, here's the great part. It's not like the treatment's going to drastically change. I mean, frankly, it could a little bit. Most of the time, if we allow this to happen, patients will actually outdiagnose doctors oftentimes, because again, they're focusing on what's important to them. Getting the patient involved in that process, it just takes the pressure off, because oftentimes, dentists are thinking, gosh, I don't know how comprehensive I should be. I mean, this patient, there's a whole lot going on here, but I don't want to overwhelm them. And so I think today I'm just going to diagnose what's broken. Okay. And then we'll talk about the rest later. Well, how fair is that for us to decide, or for the dentist to decide, which patients get to hear about long-term comprehensive preventive dentistry? That's not fair. Should be up to them. And, we'll talk about how to take that pressure off of the dentist, off the supporting team, so that really the patient's making those decisions. Okay. So the questions, remember, as we look at these questions, are completely unique to the patient. Now, here's what open-ended questions are not. They're not yes or no questions. Or if it's a question that starts with is, like, is there anything you want to change about your teeth? Or do you like your smile? Do you have any problems? Yeah, those are yes or no questions. Those are not open-ended questions. Open-ended questions are not intended to be manipulative. Okay, now they can be if we are, again, checking a box and asking the same questions, of patients, or if we are making those open-ended questions leading in nature, instead of really truly being curious and seeking to understand the patient. They shouldn't be scripted. Okay, now, in the beginning, I mean, I'll be honest, in the very beginning, I had a few questions. I had a script, so to speak, but that was just to kind of, give me, I guess, a little confidence in having those in my hip pocket. But what I realized is, again, those questions are unique to every patient. I may have had one question in general that I asked most patients to start with, but the next question was determined by how they answered that question. Patients will tell you what to ask next if we're really listening. The problem that I had in the beginning, I think a lot of us do in learning this kind of communication, is we're thinking too much about what we're going to say next, okay, instead of listening. And then we're kind of stumped, like, okay, now what? And we didn't even hear what the patient said. So it's not scripted. It's not a checklist of questions. It's just a form of listening well. Okay. So let's look at some examples. And again, these are just a few examples. You'll get the QR code. You don't need to write these down. I mean, you can certainly, take a picture with your phone, screenshot or whatever, but I will be sending those who request these a list of open-ended questions that will include all of these. But you'll notice they start with what, how. I don't have any whys here, but you've got lots of options. These are just some examples so you can get a feel for what we're trying to accomplish. What are you looking for in a dental office? That's a great question to ask over the phone. It gives us so much insight in terms of thinking beyond just I need to come in to get my teeth cleaned, or I've got a broken tooth I need to get looked at. It helps us understand lots of things. And I've been amazed at what people share when you ask that question. Anything from, well, I remember asking that question, and this was probably the most odd answer. I want a dentist where the team gets along. Like, whoa, okay. And then the patient, continued to share, there was just a lot of tension. There was a lot of tension, and it was very uncomfortable for me, and I could feel it. So, little side note here on your practice culture, you can't fake getting along. Okay, you can't fake harmony. If you've got tension and you've got underlying issues amongst the team, you got to fix that, because all the open-ended questions and all the other things in the world are not going to make up for the fact that there is underlying tension. Patients can pick up on it, and like that patient, maybe they can't put their finger on it, but something doesn't feel quite right. So that's a little bonus for free. So that's a great question. What do you want to accomplish other than a cleaning? Okay. Most of us know that sometimes patients call and schedule a cleaning because they don't really know what else to schedule. But by asking that question, they give you a lot of additional information. Oh, well, I've got a sensitive area, or I want to know if I have any cavities, or I want to talk about whitening, or my last dentist told me I've got some stuff going on, and just want to kind of see what I need to do, come up with a plan. The next one, what benefit do you see in waiting until it hurts? Now, obviously, that's not a question you're going to ask everybody, but this is where that question would be helpful. If you've got a patient that says, I'm just going to wait until it's a problem. Got a lot going on right now. It's crazy to me to even say this out loud, because it doesn't seem logical when a patient says, I will wait until it hurts. I mean, that's kind of the equivalent of me going to, a few weeks ago, had to go and get a nail taken out of my tire. It had a slow leak, couldn't figure out what's going on. Went to Discount Tire. They said, oh, you've got a nail in your tire. No, by the way, it looks like you need a couple of new tires. Your tread's pretty low. It would have been totally illogical for me to say, you know what? I think I'm just going to wait until I have a blowout on the freeway and then I'll come back in. I mean, really? That just doesn't make any sense. There is another reason why your patients are saying that. Okay, they're either concerned about the cost, or they're overwhelmed with their schedule, they're fearful, who knows? But until we uncover that objection, we can't help that patient. So, what typically happens when they say, well, I'll just wait until it hurts, is we start educating and explaining, oh, well, you don't want to do that, because if you put it off, you're probably going to need a root canal also, and we start this scare tactic thing, not intentionally, but again, it's just kind of how we've evolved and how we've typically communicated. So instead, we want to ask a question. Hey, absolutely, you get to decide the time frame. It's your plan. Help me understand what benefit you see in putting it off or waiting until it's a problem. Okay. Now, you could even preface that with, I am so glad it's not hurting you yet. But asking that question, what benefit do you see in waiting until it actually gives you problem? That uncovers the objection. Well, I'm just really busy right now. Or, this is just a lot of money. I don't, really have that right now. Or maybe they'll share that they're just a little nervous. And so then you know how to deal with that. If you need some help dealing with objections, I'll share my information at the end, and I'll send you lots of information on how to overcome those objections: money, time, fear. So let me know if that's something you'd like. How do you see us helping you today? Okay. Great question. We make assumptions, or again, we put them in a box and say, well, what we normally do on new patient visits is blah, 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 blah. This is what we do. We put them in the box. But rather, I think we ought to ask, how do you see us best helping you today? Okay. Give them the dignity of being part of the process, right? How long do you want your dentistry to last? Now that, when you're working on formulating a plan, or maybe patients say, that's filling versus crown is a great example here. Patient comes in with a broken filling, and there's not enough tooth structure left to do another filling. And that's kind of what they're asking. And you say, well, you don't have enough tooth structure left. You really need a crown. And they're like, wow, gosh, can't you just do another filling? That other one lasted 25 years. And then this question, well, how long do you want it to last? How many times do you want to have to work on that tooth? And so that's sort of the context in which that question would be helpful. How can we make sure you're as comfortable as possible in our office? Okay, that's a great question for hygienists to ask once you get them in the chair. Anytime you've got patients who maybe have shared or indicated that they've had uncomfortable experiences, or you pick up on the fact that they're fearful or anxious, I think those are great questions to ask. Right. So those are some examples of open-ended questions. Future focus questions. These are another kind of a subset of open-ended questions that get us thinking beyond today's problems. Okay. So we want to make sure that we are not asking questions that are just about today. Patient comes in for a cleaning, for example, new patient. We don't want to ask questions like, well, what do you want to change about your smile? I'm like, whoa, I'm just here for a cleaning. Unless they've indicated that that's something important to them. We don't want to ask, we'll talk about here towards the end, some questions that are problem focused or crisis focused, like, do you have any problems? Anything bothering you? Instead, we want to ask future focused questions. How do you feel about prevention? Okay, have you ever had a dental emergency? What if we could help you prevent that down the road? What do you want your teeth to be like 10 years from now? Okay, how much dentistry do you want to have to worry about in your retirement years? Of course, that's an age appropriate question. How proactive do you like to be with your teeth? So those are obviously open-ended questions, but they're, again, what we call future focus questions that gets the patient thinking more preventive instead of, is anything bothering you today? And we'll talk about what's wrong with that question here in a little bit. You can scan this if you haven't had a chance to yet. I'll have it at the end as well. So we can kind of cruise on. All right, so the other problem, or the other kind of the second mistake that we make, is we technique things. Now, what I mean by that is we have scripts, or I practiced kind of in a former life in the dental practice I worked in, where kind of learned the most about patient communication. We went through a lot of consultants and went to a lot of courses and did a bunch of things. And a lot of it basically involved these technique driven processes. Okay, where we memorize things and we had to say them verbatim. We had to say it exactly as it was. Personality profiling of our patients. And I'm not saying that's not helpful, but it's just one component. It can't be what drives everything. But the script memorizing, all of those things, I mean, sometimes it worked, but at best, most of the time we were worse off than we were before. It was very awkward and uncomfortable. It seemed insincere, and I felt kind of icky. I'll be honest with you. I just felt kind of icky. I remember thinking, man, I went home and told my husband, I'm going to have to get a new job. I don't like selling things. And frankly, people either need dentistry or they don't. And I think it's ridiculous. And I think I even used the term unethical to try and sell dentistry. Well, boy, was I wrong, because anytime people are exchanging money for some kind of a service or product, you're a salesperson, like it or not. And we don't like that sort of persona. We don't like to feel like a used car salesman. But that's what happens when we use techniques. Patients sense duplicity, they pick up on it, it doesn't feel good. And so, talk about manipulation. I mean, they don't understand what your motive is, so they don't feel comfortable opening up and sharing. And you may hear things like, you know what, I'll just wait till the dentist comes in, because it just feels odd. So you have to be genuine, you have to be sincere. Otherwise, it's not going to work. So talking more about these techniques, like I said, it's not about memorizing scripts. It's not about trying to be someone we're not, following a cookbook, getting more bodies through the door, throwing more money at our case acceptance or lack of production problems. That's not what we want to do. I have heard this a few times, and there's anyway, someone out there that uses this term, more butts in chairs. We need more butts in chairs. That, talk about feeling icky. That just feels icky to me because it dehumanizes your patients. Okay. That's not what we want to create. It's, we want to be able to serve more people. We want to be able to help more people get what it is that they want. We don't want more butts in chairs. I mean, I just don't like the way that feels. When we talk about throwing more money at problems, maybe it's, well, we just need more new patients. Well, I'm here to tell you, I have seen practices thrive. If we're talking a single doctor practice, I've seen them thrive on 15 new patients a month. It's where they're coming from. It's what are we doing with those new patients? How well are we listening? What is the process? How do we bring them in? How well, are we going through that process? But then on the other side of that coin, I see single doctor practices that have 60, 70 new patients a month, and it's not enough. So what's the difference? I think if we're looking at, well, we just need more new patients, maybe, certainly maybe, but it could be that we haven't gotten our skills to the point where we can help the patients that are coming to us. And so, we've got to look at that and make sure we're not just throwing money at more marketing and I'm all for marketing, don't get me wrong, but it has to be coupled with improving our skills so that the investment that, you guys are making in marketing is worthwhile, because we're also improving our communication skills. Sometimes we throw, dentists will throw money at some of the problems by getting a new piece of equipment or the newest, latest, greatest technology. And again, that's all really great stuff. But if we're looking outside of ourselves to increase revenue, if we're doing that, without looking, inward first, that's a mistake, because again, it's going to be a futile effort, because we aren't maximizing what's right in front of us. We're not able to take care of the patients we do have in an effective way. All right. When I talk about skills and improving our skills, that is not a technique if it comes from a sincere desire to understand the patient. Okay. Now, the best way we can do this when we talk about open-ended questions, which is our focus tonight, if we can practice communicating in that way with our family, with our friends. Next time you go to coffee with a friend, instead of sitting down and saying, "Oh, you wouldn't believe the week I had. Let me tell you everything." Sit down with them. "Hey, how are your kids doing? Tell me what you have that you're looking forward to. What exciting is going on in your life? Be curious, be interested." Same thing with your kids. My kids are fully adulting now, which is, that's exciting. Miss them sometimes, but I think we did okay. They're 24 and 28. I have two girls. And when they were younger and I'd pick them up from school, one just loved to talk. I wouldn't have to say a word. The other one was very quiet. And I would say, "Did you have a good day?" "Yep." And so what I had to learn to say instead is, "What was the best part of your day today?" And then she'd start talking. It's amazing how that works. But I just switched from a yes or no question to an open-ended question, and I got more engagement from my kid. Okay, so, and now, they're older, and it's still the same. I have one that just loves to talk, and the other one, You know, no news is good news generally. But when I am around them, I know how to engage them. And that's important. We can't compartmentalize this kind of communication. You can't say, yeah, oh yeah, I'm with patients in the office, so I'm going to ask open-ended questions. For this to stick and become sincere and genuine, you have to just kind of make it part of who you are and how you communicate. It's that way with anything. All right. So when we talk about, again, the road to effective case acceptance, it's about learning these effective communication skills and applying them to all areas of your life. Remember, you simply cannot compartmentalize it. It's kind of like a lifestyle change. You know, I will admit, I have in my lifetime, I have looked for lots of magic pills, okay, generally to do with my health, weight loss, being healthy. Boy, take this pill and you don't have to exercise and you lose weight. I mean, I think we all do that. We look for that magic pill and want something to fix quick without us having to change, without us having to go through any pain of change. Okay. But this is just like a lifestyle change. Just like there's not a magic pill for weight loss or getting healthy, there's not one for success in your practice. And again, you can't compartmentalize it. It's just something you embrace and you learn to communicate this way with everyone in your life. Okay. So the third thing, we confuse patients. So how do we do that? Well, because of the traditional ways we've all been taught, like I mentioned earlier, we become our own worst enemy. We shoot ourselves in the foot. You know, even some of the state-of-the-art, wonderful, fabulous technology that we have can sometimes, if we're not careful or don't approach it the right way, it can actually create more hoops for the patient to jump through and make it more difficult in terms of case acceptance. So let's dig into that a little bit more. We need to understand, first of all, that even us, even dental people, make decisions emotionally. We make decisions on where to spend our time and resources based on how we feel. And so people want to spend their time and their resources in places and with people that make them feel good. So what makes people feel good? Well, being heard, being understood, not being judged, you know, not feeling hopeless, you know, being heard. And I think we've got to make sure that we understand that. Yeah, think about the last thing you bought. Okay. I mean, the last large purchase I made was a car here recently because my 11-year-old Dave Ramsey car finally bit the dust. And so bought a new car. Well, I will tell you, you know, I initially went into it trying to be very logical and thinking, you know, I don't need this, I don't need that, I don't, you know, whatever. But I will tell you, you get in that car and it's that new car smell and even some of those bells and whistles you think you'll never need. It's just like, oh, yeah, this is it. This is what I need. And so then we begin to, you know, where logic comes into play there is once we make that emotional decision, we may start bringing in logical thoughts or facts to justify our emotional decision. Okay? Patients are the same way. And here's the thing, I've got you know, kind of a news break for you. They do not want to buy your crowns or your implants or your scaling and root planing, but they do want the benefits that those things offer. The problem is we spend too much time focusing on the parts. Okay. And so we have to shift. We have to shift to having more relational, more emotional conversations with patients versus transactional and just nuts and bolts of here's what you need, here's why you need it. And if you don't do it, here's what's going to happen. Right. So we have to understand that, you know, people make decisions emotionally. All right, so here's how we're confusing patients. We're trying to sell them on the 3 Ps: parts, process, and procedures. We are get really excited about the technical aspect of dentistry. So we educate a lot. We might even get real involved in offering all of the options. Okay, well, you've got this missing tooth. Well, let me tell you all the things that we could do. Okay, we could do a partial, which is like a retainer with a tooth on it. It's going to come in and out. We could do a bridge, and we explain how we do that, or we could replace it with an implant. And here's the cost for each one. And we share so much information. Not only does it take a ton of time, but patients' eyes are glazed over. That they don't know what to do. They're paralyzed because they're confused. And so getting technical is not where we want to go. Okay. Now, I will tell you, patients will even ask you what appear to be technical questions. But I'm going to give you again kind of a little extra tip here. I would ask clarifying questions. And here's an example. I remember as I was learning this process that patients don't want technical information. They just care about, 4 things. What is the time commitment going to be? What is the financial commitment? Are you going to hurt me? And when it's all said and done, am I going to be happy? That's all they care about. But I remember a patient who I was actually had gotten scheduled. It was her treatment planning appointment, had gotten her scheduled. She even prepaid. I had a check from her. And then she looked at me and said, Amy, how exactly is Dr. Taylor going to do this? I'm like, oh, no, we're not supposed to explain the process. And I felt very guilty. I felt like I was withholding information. And boy, was I wrong, because I was looking at it through my lens and what I would want to know. And I just assumed patients were like me. Well, newsflash, they're not. And it's wrong for us to assume they are. And so sitting there in that moment, and I was, really frustrated because I knew I couldn't start explaining, but that's what the patient asked for. So, I kind of had a light bulb moment, and I just turned to the patient. I said, tell me what you want to know about the process. And she said, I just need to know if my husband's going to need to take off work to drive me, or if I can drive myself. Like, wow, that was easy. And if I would have started explaining the process, I would have lost her and would have never even answered her question. So by just pausing for a moment and asking that patient a clarifying question, I was able to answer it very easily, and we moved on. And so we are confusing patients because we are sharing information in our frame of reference. And again, we've got to stop doing that. There are lots of times where, again, thinking of your own personal situation where you're in a buying situation and you leave empty-handed because you're overwhelmed. My husband had to buy a tie. He doesn't typically wear a tie, but he was looking for a tie for a wedding a while back. And we were at the department store, and I went one way, he went the other. We were out of town, and he was going to get a tie, a blue tie. So he goes to the tie counter, and I did all the stuff I was doing. About 30 minutes later, we had a meeting point, said, meet me here in 30 minutes. We met there. I had like 5 bags. He had nothing. I said, wait, where's your tie? We got to go. He said, well, I went to the counter and I asked for a blue tie, and she pulled out like 20 blue ties, and I was just overwhelmed, and I, was stressed, and I just didn't know what to do. So I didn't buy anything. So of course we traipsed back over to the tie counter and got that worked out, but he was overwhelmed. He was confused. And, when we offered too many options, it's hard for people to make a decision. Now, I understand that, kind of getting back to this, I totally get the fact that, you want to make sure patients are informed and understand what their options are. But I'm here to tell you, if we ask the right questions, we're going to know the best option to share with them. If we're asking those questions like, how long are you wanting your dentistry to last? How important is it to you that, with this missing tooth, that it's something that's permanent, that doesn't come in and out? If we're asking the right questions, their answers are going to point us to their desired solution. We just need to listen well. So again, think about what we're selling. For us, we think, well, dentistry, we're selling, we're replacing body parts, or, we're selling crowns, we're selling root canals, we're selling night guards. No, we can't think that way, because that's thinking parts, process, procedure. The patient's buying teeth that look good, teeth that are pain-free, and teeth that last a long time. Okay. Now, some of those things might be more important than others for the patient, and we're not going to know unless we ask. But generally, everybody wants to be able to eat whatever they want without an issue. Most people want to keep their teeth, and few of them even care about how they look. So, you're at least going to get two of these three if we're asking the right question. That's what we need to focus on, not selling the parts and the process and the procedure. Patients want to know, what's the end result going to be? And that's where we need to focus on: look good, feeling good, pain-free, and lasting a long time. All right. So how do we know we've confused a patient? If you confuse, you'll lose. Again, that is a quote from my favorite marketer. His name is Donald Miller. He's a guru on websites, all kinds of things. He's written some books. He's speaking out there. But if you confuse, you'll lose is something that I think we've got to remember. But patients might even say things to you like, wow, I have never had a visit like this. I have never had somebody spend 2 hours with me. That's awesome. I'll get back to you. Again, it's just information overload. If we give them so much information that their brain has to burn a bunch of calories to figure it out, they're gonna come to a standstill, and they're not going to be able to make a decision. Now, this isn't always the case, but many times they say, yeah, I'm going to have to go home and talk to my spouse. Well, I don't know about you guys, but I've been in buying situations where really maybe I didn't have value for it, or I was confused or overwhelmed, and I just needed a minute. So I blamed my husband. Yeah, I'm going to have to go talk to my husband. I have to talk to him before I spend any money. And so sometimes that's an excuse because they're overwhelmed or confused. Now, having said that, I totally get that. And in many cases, it's perfectly appropriate. I don't want to question patients' integrity. They may seriously want to go and talk to their spouse. Nothing wrong with that. Or they might be kind of stuck in the insurance world. Well, what's my insurance going to pay? I mean, I guess if they're going to pay it, I'll do it. They're looking to their insurance to make the decision for them because they're confused and overwhelmed. Or it might be as simple as, yeah, I'm going to have to think about this and get back to you. Okay. Those are pretty good indicators that your patient is confused. All right. So number 4, we steal ownership. I mentioned this earlier. So what does that mean? This word right here, and I'm going to give you guys some words to eliminate from your vocabulary, and this is the first one. When we use the word need, we're stripping ownership away from the patient. Okay? When we tell our kids, you need to pick up your shoes, you need to get a job, you need to do this, you need to do that. None of us like to be told what we need to do. I'll tell you a little personal story. A few years ago, I had a doctor that I'd seen, gosh, for years and years and years. I mean, he delivered my kids. I went to him every year, just very, knew him very well. And he was always on my case. Amy, you need to lose weight. Amy, you need to stop eating sugar. Amy, you need to lower your blood pressure. And so that, every 12-month visit turned into, every 18 months, every 2 years, every 3 years, because frankly, I didn't want to go and get chewed out. Okay, because I knew what was coming. In fact, just like your patients may try and make up for 6 months of not flossing, on the way from the parking lot to your office, I would try and make up for, a year of not exercising or eating right. It doesn't work. Doesn't work. Patients can't hide their lack of flossing, just like I couldn't hide my lack of, eating well. So this word need, we've got to get rid of it. Here's what happened. I started going to a new doctor that I heard some really good things about. And when I went in, he asked me, tell me why you're here. He didn't say, well, here's what we're going to do. This is what we do on all new patients. We're going to do this, this, and this, and this. He said, tell me why you're here. I said, well, I need to get a little healthier and I need to lower my blood pressure. And he said, okay, why do you want to do those things? And I'm like, duh. I mean, and he was kind of persistent with that question. And really, it kind of resulted in me getting to the crux of why I really wanted to do that. At that point in time, both my parents were on all kinds of medications, had type 2 diabetes, had all these health issues. And, I would go over there and see their shoebox of medications they were each taking. I'm like, I never want to be that. I just don't. That's just, if I can control it, if I can do things that will result in better health that I do have control over, by golly, I'm going to do it. And so that evoked a lot of emotion. He asked me open-ended questions. Imagine that. And by doing that, I felt empowered. I sort of discovered my real why and why I was going to the doctor and wanted to do that. And then here's the best part. Instead of throwing blood pressure pills at me, I mean, he did give me a prescription, but he said, now tell me what you want to do. I mean, you can take this prescription indefinitely, or would you like to know why your blood pressure is high? It's up to you. And I thought, oh, well, that's kind of, refreshing. I said, well, gosh, I want to know why. Because, and he asked that question because he was clearly listening to me and sharing my experience with my parents and how I didn't want to go down that road. And so that resulted in, some tests, went and had a cath and all these different things. And the good news is there was absolutely nothing wrong with, or nothing physically going on to explain my blood pressure issue. And what we discovered is it's how I was manifesting stress. And then we knew how to deal with it. But the fact that he gave me or empowered me to be a part of the solution resulted in that outcome. Okay. Otherwise, wouldn't have gotten there. I would probably still be avoiding the doctor and may very well stroke out because of that. So that's huge. Get rid of this word. Need is not something we ought to be saying. You need this, you need that, you need to floss more, you need a crown, you need to come in more regular. I mean, just get rid of it, because when we use that word need, we are stripping any ownership that patient may have. And when we do that, here's why that's a problem. When we do that, they, to use the word comply, they just don't comply. They don't accept treatment as well. They question things. Again, they look to their insurance. Gee, it doesn't hurt. It's not bothering me. I mean, don't you guys wish periodontal disease hurt sometimes? Problem is it doesn't. So, again, we want to be asking the right questions. By the way, again, this is for free. Again, more bonus. Here's some other words to add to those lists of things you don't want to say. Policy. Just get rid of that word. Policy. Nobody likes policies. If you want more information on that, I'd be happy to share my perspective on that. Any negative words, we can't do that, or we don't do that anymore. Unfortunately, we're not open on Fridays. Focus on what you can do. Friday appointment, well, actually, we reserve time, especially for new patients, Monday through Thursday at 11 o'clock. Which one of those days would work? Okay, instead of focusing on what you can't do or don't do or won't do, talk about what you can do. All right. So again, just a little side note there. Whoops, sorry, jumped ahead here. When patients are allowed the dignity of being a part of the process, everybody wins. I'll tell you, one of the most powerful tools that you have, in addition to asking questions and listening well, are photos. Okay, again, that's an emotional tool. Patients understand photos. They can interpret them. We try and give them radiology 101 and say, see that shadow, see that dark spot? We try and explain what's going on in x-rays, but remember, that's technical. Okay, photos are more of an emotional tool. They can help co-diagnose, if you will. They have ownership when they see photos of their mouth. So if you'd like more information on what kind of photos to take, I can certainly share that with you. So let's look at this. This is quite a controversial thing that I say. Oftentimes people say you have to educate patients, and I 100% totally agree. The problem is the order in which we typically do that. We do it in the wrong order. Okay? We try to educate in an effort to convince patients to do something. Okay? Education is necessary, but education we shouldn't lead with education. We should be leading with curiosity. We should be leading with questions to empower the patient, allow them to be part of the process, etc. And so, make sure that we're not skipping education. But if you look at what's interesting, if education sells, because I get in this discussion quite often with folks, then why do we have overweight cardiologists or doctors that smoke? Or, ask your dentist, when was the last time you had your teeth cleaned? Or how often do you floss? I mean, we're just like everybody else generally. Might be a little more aware. Certainly we're more educated, but we're also oftentimes like the cobbler's kids that have no shoes. We might get thrown in the chair if there's an opening, but we don't take on the same value system, and for ourselves that we want the patients to have. Some of you do, and that's great. I know I didn't. But it just doesn't make sense for us to only educate. Education comes after we find out what the patient wants, what's important to them, what they value, what their objectives are, both short-term and long-term, and then we educate them according to what they want. And again, patients want teeth that last a long time, that they can chew comfortably with, that don't hurt, and some even care how they look. So they want the same thing you want for them. We just need to learn to take their road instead of ours. And we're going to end up in the same spot. We're just going to get to help a lot more patients. Okay. It's not about us. That's kind of the whole theme of this, is realizing it's not about us and trying to get patients to think and see things the way we do. It just doesn't make sense. All right, number 5, we make assumptions. So what do we make assumptions about? Well, we assume patients can't afford treatment. We assume they're going to base their decisions on insurance, or that they're going to want the cheapest option. Or like I mentioned earlier, we assume patients think the way we do, or we assume they won't schedule, based on various things. So here's what we need to stop doing, is assuming things about patients. See, a problem I had, and I tell on myself a lot, because this is all kind of learning by failure, if you will. One of the things that I had a problem with in the beginning, this was several years ago in the practice I was working in, the doctor decided to go out of network with PPOs. And I said, well, that'll never work. I mean, I wouldn't want to go to a dentist that wasn't, in network, or a doctor for that matter. And so that was my frame of reference. Okay. At that point in time, my husband and I had just had our first child, our baby, who's now 28. And she, had just started daycare. And I think we had $14 left over every week after our budget, after we paid for daycare and baby formula and diapers and groceries. It's like, we had literally $14 left every week. So that's my frame of reference. And I'm thinking, well, we're penny pinching over here. I mean, forget if I want to go to somebody, there's no way I could. Well, then came the proposal that we ought to pre-collect from patients to ensure they show up, because we were having problems with patients canceling at the last minute or no showing. And by the way, I'm a big fan of that now. But back then I was thinking, oh, no way, that's not going to work. Patients aren't going to want to pay for something before they have it. I mean, I wouldn't. So we can't assume. I mean, I was not the typical patient. I just assumed that everybody thought the way I did. We assume based on a patient's appearance that they're either going to accept treatment or not. We make all kinds of assumptions. I mean, that's human nature, but we have to get out of that. We cannot impose our value system on patients. We just simply can't do it. Okay. Let's talk about, because I know money is a big objection, but one of the things I realized over time is that when patients say that's a lot of money, I can't afford it, most often it was really a value issue, not an affordability issue. And if that was the case, that was on us, because we didn't find out what they valued. We didn't find out what was important to them and then match a solution to what they valued. We were just telling them what they needed. Okay. So when we talk about that, I mean, I'm sure you guys have been in the same situation where, again, you're in a sales situation and You have the money, but you say, I can't afford that. You don't want to afford it because it's not important to you. It's not something that you value. And that's why we need to find out what patients value. You know, I was on a Zoom with 2 practices back to back yesterday, and the first one, they said, you know, nobody can afford dentistry right now. I mean, you know, there's been some winter storms, and, you know, everybody has had to miss work. And, yeah, they just went on and on with all these reasons. Nobody can afford dentistry. Nobody can afford dentistry. And I said, okay, well, what about your third party financing? Oh, nobody wants to apply for that. And right there, that's a red flag indicator that it's not an affordability issue. If they really valued the dentistry and wanted it, I mean, this is America. People figure out ways to get what they want. I mean, I'm all for not going into debt, but the reality is if people really want something, they figure out a way to get it. The problem is we have not found out what they value and match that to our solution. We're still over here in our frame of reference. So there's a big difference between value and affordability. And you know, I think when we realize that difference, we've overcome a lot. All right, last thing, we ask dumb questions. I alluded to some of these before. This was my number 6 that I just really had to add. You know, this is a tweet that I've hung on to obviously for what, 10, 11 years. But I love it. I get the same feeling at the dentist that I get when a cop car is behind me. I haven't done anything wrong, but I feel really guilty. You know, and that's, I mean, is that how patients really feel? Yeah, I think it is in many cases. So dumb questions we ask. Well, we ask crisis focus questions like I mentioned earlier. Is anything bothering you? Do you have any problems? Are you in pain? What's your chief complaint? I mean, you know, that's something that I can't believe we're asking that, but we do. And what we need to realize is that these questions, if we're asking patients, are you in pain? They're like, nope, just here for cleaning. And then the hygienist looks in their mouth and it's a train wreck. Where do we go from there? Because we've asked those crisis focused questions, we have then, you know, by our own doing, we have helped the patient connect the dots from, well, if I'm not hurting, I must not have any problems. Okay. And so we've got to stop asking these questions over the phone, you know, chair side, whatever. We just have to stop asking those questions because, you know, you're not going to be able to help patients prevent issues or get them out of that crisis-based mentality by asking these questions. All right. So some of the other dumb questions we ask, you know, are, again, let me get back here for just a second. Whoops. Might be, have you had any bad, I don't have these on here, but have you had any bad dental experiences? You know, things like that. You know, we want to stay away from that as well. And I get the motivation. We want to understand, you know, want to make sure we don't repeat any of that. Well, you can accomplish the same thing by some of those other questions we mentioned earlier. How can we make you as comfortable as possible today? You know, what are your expectations for today's visit? I mean, we can accomplish that in a different way without bringing the focus to these dumb questions or to negativity through these dumb questions. All right. So again, our 6 things: we talk too much, we technique things, we confuse patients, we steal ownership, make assumptions, and ask dumb questions. Those are things that we do. And again, unfortunately, it's sort of how we've been brought up in dentistry that get in the way of case acceptance. But if we'll slow down, if we will listen, if we will learn the right questions to ask, if we'll stop making, you know, assuming that patients think like we do, we're going to be a lot better off. And so is the patient, frankly. Okay. All right. Again, here's that QR code that you can scan if you'd like. A very long list of open-ended questions. I'm also going to put in the chat, because I mentioned a couple of other things. If you guys need any blanks filled in, or, you know, I know I went pretty fast trying to get everything in an hour. I'm going to put my phone number and my email address if you've got any questions or if you want to get any additional information. There we go. Fat fingers, sorry. Okay. All right, so there's my phone number, my email address. Feel free to give me a shout and I'll be happy to share any information with you or fill in any blanks. So,
Thank you
we're
so much.
on.
Yes, Amy, thank you so much. There were so many great pearls of wisdom in there, and I know I learned a lot, and I'm sure everybody else did too. Thank you, everybody, for attending tonight, spending an hour with us. Remember, our next webinar is going to be on March 19th with Lynn Pensek. She's going to be covering dental implants, parts, pieces, chemistry, and compatibility. So we hope to see you guys again there or at one of our future events. Thank you again, Amy, so much, and have a good night, everyone.
All right, bye, guys.
Bye-bye.